Hi, thank you for joining today. Welcome to the Alaska ID Echo, hosted by ANTHC's Liver Disease and Hepatitis Program and the HIV Clinical Services team. My name is Jennifer Williamson, and I work with the consultant team to coordinate this echo. Please feel free to contact me throughout today's session via chat, or you're always welcome to email me, and I'll put my email in the chat as well. You may have noticed the didactic, the echoes recorded. We record through the didactic presentations, and we make those available on our webpage for future viewings. And we will be saving questions for the end of the didactic presentations. Feel free to go ahead and add them into the chat or direct message them to me if you'd like throughout the presentation. And also, we'd love to hear where you're joining from, so if you could add that into the chat as well. Our ECHO consultant team is available to provide input on patient cases. We invite you to submit a case or questions for treatment recommendations by the team, and that which includes hepatologists, pharmacists, and infectious disease specialists. The monthly series is approved for CEs and CMEs, and some sessions are eligible for pharmacology credit. Additional information I'll be putting into the chat. At the end of the session, I'll be entering the evaluation link to claim CEs into the chat, and I'll also send it out via email with the presentation slides. And I'm going to go ahead. We'll be getting started here with our presentations. Today's didactic will cover HIV and STI epidemiology in Alaska, and will be presented by Sarah Brewster and Nathan Worthington with the State of Alaska Department of Health. And with that, I will go ahead and hand it over to you, Sarah. Thank you so much for presenting.
Hello, everyone. So I will be doing the HIV update for Alaska. I'm not sure if there are new people on the call. I apologize. Hello. If we haven't met.
Sarah, if you can hear me, we can't hear you that well.
Interesting. Better, worse. Is there any improvement if I do that? Yes. Okay, cool. Thanks,
Yes.
Anna.
A little bit, yeah.
Sorry. Okay. Well, I will project in my office. I always have a microphone issue, so I apologize. Fortunately, the slides are detailed, so I will be summarizing the slides. For those of you I haven't met, though, I do serve as the HIV surveillance coordinator for State of Alaska. Next slide. So this is long-awaited 2021 update for folks, and I know it's been long-awaited as I think we've collectively discussed in many discussions and meetings with COVID. We've had to do a lot of data cleaning and data finalization. Nathan will touch on that some more. These data are still in final review for publication. The data itself will not change numbers-wise, but language may be updated, particularly COVID caveats. And as with 2020 data, 2021 data should also be interpreted with caution due to the impact of COVID-19 on access to HIV testing, prevention, and care-related services. Next slide, please. So for cumulative cases from 1982 to 2021, 2,095 cases of HIV have been reported to Section of Epidemiology. Of those, 63% ever had a diagnosis of stage 3 AIDS, 35% are known to have died, 81% were assigned male sex at birth, 61% of cases were attributed to male-to-male sexual contact, including cases attributed to both male-to-male sexual contact and injection drug use. 51% of cases, 18% of cases were attributed to heterosexual contact, 11% of cases were attributed to injection drug use. 15% of cases were among persons who identified Alaska Native American Indian. 14% of cases were among persons who identified as Black. Country diagnosis who are included in this total because we did not have an official date of diagnosis or laboratory diagnostic test to support a previous diagnosis, and so they were included in 2021 data, and they are included in these proportions as well, just based off of how the coding works and how the data is prepared. So of those 30 cases, 33% were stage 3As at the time of initial diagnosis, 3%, one case is known to have died, 83% were assigned male sex at birth, 67% of cases were attributed to male-to-male sexual contact, including the one case that was attributed to both male-to-male sexual contact and injection drug use. 10% of cases were attributed to heterosexual contact, and 7% of cases were attributed to injection drug use. Of the 30 newly diagnosed, 43% were among persons who identified as white, 30% were among persons who identified as Alaska Native American Indian, and 13% were among persons who identified as Hispanic Latino. 67% were residing in Anchorage, Mount Sioux at the time of diagnosis. Next slide. So this is reported cases of newly diagnosed HIV in Alaska by year for the last 10 years. Again, we have been fairly consistent. 2020 and 2021, again, need to be interpreted with caution due to the impact of COVID-19 on testing, prevention, and care-related service. We do know statewide that there was quite a reduction in testing, both for large facility and outreach events. So something to consider for sure in reviewing this data. Next slide. Here we have reported cases of HIV newly diagnosed in Alaska in 2021 by age at diagnosis and sex at birth. Persons assigned male sex at birth are in green. Persons assigned female sex at birth are in orange. Among persons newly diagnosed, 53% were less than 34 years old at diagnosis. For 2022 data, this is obviously preliminary, but it's trending downward quite a bit. So we do have quite a few folks who are quite between the ages of, I would certainly say, 15 to 30, which is not broken out in this graphic by any means, but something to consider. We are seeing a larger proportion of newly diagnosed among a younger group of persons. Next slide. This is 2021 data, reported cases of newly diagnosed in Alaska by race, ethnicity, and sex at birth. Again, Hispanic, Latino are all races, and I should have said this earlier in the previous slide. Hispanic, Latino, it's weighted variable, so it captures all races, and multi-race is more than one race or race category, excluding Hispanic, Latino. Something to consider in looking at this, but fairly consistent with what we've seen in previous years for proportions. Next slide, please. And here's the pie chart of the breakdown for 2021 data based off of transmission category. Here, MSM and MSM IDU are broken out separately, but combined 67%. Obviously, the majority is male-to-male sexual contact. Other not specified, that sort of teal, lighter blue color. I'm not sure if we've ever specified what that breakdown is, but just for continuity and for folks who've maybe not seen this data, that designation, that transmission category is a catch-all, so it includes hemophilia and blood transfusion, as well as risk factor not reported or not identified. No identified risk is when no known risk factor was identified or calculated. Again, some of these transmission categories, particularly if a person reports yes for more than one category, there is a weight internally within our surveillance system about attributed risk. And so those are calculated within the surveillance system. And so that's what it means by calculated. And then no risk reported when a person did not report any potential attributed risk behavior or risk factor. the reported cases of HIV newly diagnosed in Alaska by residents at diagnosis. Again, Anchorage, Mat-Su, largest proportion, and then we've got interior, Southwest, Southeast, and Gulf Coast. Next slide, please. Here we have persons living with HIV in Alaska as of December 31st, 2021, total of 723 people estimated. We had no reason to believe that they were no longer living and no longer residing in Alaska. So this is the breakdown of diagnostic criteria, demographic, and residence of diagnosis. And just for the sake of time, because I know Nathan has quite a few slides, I'm not going to go through this, but please review later or as necessary. Next slide, please. So our HIV care continuum includes all persons with HIV who lived in Alaska during 2021. So you'll see that this total is slightly higher. The previous slide is as of, and this includes all of 2021. So of the 757 persons living with HIV during 2020, living in Alaska with HIV during 2021, 642 were engaged in medical care, and of those 589, 92% were virally suppressed. We do anticipate that this data may be slightly underrepresent the number of persons linked to HIV care as well as virally suppressed, just due to the impact of COVID. Certainly not to the same extent that we anticipate data to be impacted by in 2021, but certainly something that we have to consider. A lot of folks were in care and not getting labs, and so their viral suppression is not counted in these data. Next slide, please. And then this is just, we can't do a presentation without bringing up the algorithm. And so I'm sure folks on this call can attest, at least with some of the folks who I speak with quite frequently, we are seeing an increase in HIV screening at a number of facilities and facility types. And with that, we're seeing quite a few initial reactive screens. So step one of that HIV testing algorithm, which is the 4th-gen screen that we see here right at the top, HIV AG-AB combo with reflex. This is just a reminder to ensure that algorithms are getting completed. It is a significant part of my daily workload to make sure that this is happening and folks are getting their results communicated appropriately and testing is being completed. This person is a good representation of importance to complete algorithms. So this patient at day 0, first test day, was reactive on the 4th-gen screen, was negative on the antibody confirmation, which is step 2 of the algorithm. And then there was insufficient specimen for send out for the PCR test, step 3. They were perceived to be low risk or self-reported low risk, provider perceived low risk. And so testing and redraw was not completed until day 14, at which time they were again reactive on the 4th-gen screen and then subsequently positive for HIV-1 on the antibody differentiation. And so at day 0, we would have anticipated that this PCR would have been positive for HIV-1, indicative of highly acute infection. Still within early infection with these labs and with a 2-week turnaround, but something to consider. And also with HIV testing and algorithm completion, it is important. It has come up, I would say, more frequently in the last 2 months or so, particularly as we've seen an increase in screening. And like I said, I don't want to say notable increase, but certainly some reactive 4th-gen screens, at least among folks who haven't been tested in the last year or 2 years. That facilities have had questions about understanding how their algorithm works internally, whether or not they're able to do the initial screen and then do the subsequent antibody confirmation in-house, or what is sent out. And so this is just a reminder to be familiar with how your facility processes these lab results, the internal language on those lab results as they are seen in medical records and then reported to patients by nurses or follow-up care or providers. Obviously, I'm here to help support or answer questions along the way, but there's certainly need, I think, for internal review. But yeah, please keep me posted if anything comes up weird or wonky. I certainly get the 4th-gen reactives reported to me. So hopefully I'll have folks on my radar before you call, but it may not. And yeah, next slide. I think we're doing questions at the end, so I'll hold and I'll take a peek at the chat if anything comes through. This is my contact information here. That is my desk line. Feel free to call. You can also give that number out to folks who have questions, patients, other providers. The only thing I do ask is that my email not be shared with patients, just because I tend to get an overshare and also concern for what can be emailed to us without encryption from patients if I don't initiate that engagement in a secure manner. So please just provider-only questions via email. Cool, thank you.
Thank you so much, Sarah. Nathan, I will go ahead and start with your slides here.
Perfect, thank you. So my name is Nathan Wormington. I'm the STD Program Coordinator with the State of Alaska Division of Public Health. And I'll be presenting today on STI epidemiology in Alaska, so specifically bacterial STIs. Sarah covers the HIV component of it, and then we do limited hepatitis follow-up, but I'll mention that later in our testing and the DIS work. I want to thank you all for taking the time to be here today to listen to us kind of provide an update. I know sometimes the data can get a little bit dry, but it's always nice to know kind of what things are going on within the section of epidemiology, especially disease trends and timelines. So, and then lastly, I did want to mention today is voting day, so hopefully you all have had the opportunity to get out and vote. If not, hopefully you get a chance to before the end of the day. But I'll go ahead and get started. So next slide, please. All right, so this is a very busy infographic, and I'm going to start with a couple of these from the CDC. I like them because they're attention-getting, but they also have a lot of good information. I won't read through them, but I like to provide that higher level, just nationwide disease trends. Again, caveat, this is preliminary data. A lot of jurisdictions were delayed with the COVID pandemic, so we've been in the process of finalizing data cleaning and signing off on this data. So all the data throughout this presentation is preliminary. The numbers again won't change, but some of the demographic breakdowns and things that we're still working on clarifying for the CDC may have minor modifications as we sign up on those data tables. So in 2021, there was 1.6 million cases of chlamydia nationwide, roughly 700,000 gonorrhea, 172 syphilis, and then 2,700 cases of syphilis among newborns. That is a 185% increase since 2017. So that's still substantial, still notable. There have been a lot of creative conversations around STI screening, maternal screening, newborn screening, increased prevalence of testing at prenatal appointments, not just at that first trimester appointment. But the congenital syphilis rates are alarming for the nation. So this also marks the 6th consecutive year that STI rates have increased nationwide. Next slide, please. As we're all too familiar with, there's a lot of overlap. So not just within HIV, STIs, substance use misuse, hepatitis, a lot of these programs have overlap. We're seeing a lot of overlaps to the populations that we serve. And so there's been an increased conversation the past several years about how do we minimize and deduplicate a lot of these efforts. We all know that we're collaborating or interacting in different components, but funding differences and all of that have kind of isolated that. With increases in public health funding, it's increased our ability to collaborate. So there's a lot of nationwide conversations regarding syndemic approaches to provide services and address some of these ongoing epidemics. Next slide, please. So as has all been mentioned, and we've kind of speculated over the past several years, we know that the data has been affected, the numbers have been affected with reductions in testing, availability of resources, clinic availability to test and screen. And so the CDC started to try to quantify some of this with regard to the COVID-19 pandemic's impact on STD programs. So, nationwide, there's reallocation and reduction in services for clinical shifts, as well as just staffing availability and programmatic resources. Alaska specifically, there was a brief reassignment of our disease intervention specialists, and we did assist with that response in a capacity early on in the pandemic. But there was a complete reduction in field work for our staff. So we weren't doing in-field services, knocking on doors, conducting in-person testing. And there's a reduction in referral availability for clinic staff. Again, as clinics pivoted to respond to COVID and implemented safety measures, those clinical restrictions did reduce the access to care and access to testing. So again, be interesting to look at this, and it's one of those things I think will shake out over the years as we see more and more how the pandemic affected a lot of this data and these resources. Next slide, please. So the epidemiology of STIs in Alaska. Again, it remains predominantly suburban, urban. So Anchorage, Matsu region, Fairbanks, still seeing heavy concentration around those areas. Initially, the syphilis outbreak was identified in the MSM community in 2018, now more prevalent in the heterosexual community. So we didn't identify that in 2018. At this point, we're considering it an epidemic as those numbers continue to increase. Same affected populations, increase in those who substance use, misuse, particularly methamphetamines, heroin, and opiates. We do see alcohol, marijuana, other substances, but methamphetamines do seem to be one of the most commonly mentioned. Partner notification does increase testing and result in additional case findings. So we'll talk about that later on with the DIS component of the work that we do, but that is a huge component of locating individuals that may have been exposed and that may benefit from testing and treatment. Congenital syphilis rates did decrease from 8 to 5, or cases, apologize, not congenital syphilis cases did decrease from 8 to 5 in 2021. Unfortunately, we know this as a fact that this does not accurately reflect the disease burden for the state. Anecdotally, for 2022, we do have an increase in cases. So continue to screen pregnant females at that first prenatal appointment. Examination and documentation of symptoms does assist with proper diagnosis, particularly within syphilis staging, and can help reduce the costs associated with STI treatments. So I'll hit some of the numbers real quick, and then we'll talk a little bit more about the testing and treatment. Next slide, please. So from 2019 to 2021, and I'll highlight this because this is when we made a shift within our surveillance database, pre-pandemic to now. In 2019, there were 2,215 cases of gonorrhea. 2020, 1,938, and in 2021, 1,977. So with those numbers, again, should be an asterisk next to any data of 2020, 2021, as the pandemic affected those, the access to care, testing, screening, and all of that. For chlamydia, 2019, there were 6,255 cases, 4,970 for 2020, and 5,571 for 2021. So those numbers are still trending upward post that initial effect of the pandemic in 2020 as we resume testing and normal services. There's also notable in 2021, we had the STI treatment guideline updates from the CDC with the shift from azithromycin to doxycycline for chlamydia due to antimicrobial susceptibility of gonorrhea. So there's been a lot of conversations. I think I've talked with some of you on this presentation about clinical specific questions regarding treatment of individuals that have tested positive or may have been exposed to gonorrhea and chlamydia. So if you have questions with that, I know there's a shift from the dual therapy approach to monotherapy and then the changes in medication compliance. So feel free to reach out if you have any questions regarding any of that. Next slide, please. So geographic breakdown for gonorrhea in 2021, there were 1,977 cases again. So 57% of those were in the Anchorage and Matsu area, 4% in the Gulf Coast, 15% in the interior, 5% in the Matsu region, 11% in the northern, 3% and 5%, 3% in the southeast and 5% in the southwest. So again, does highlight that urban component. Again, largest population density is here, so it stands to reason, but the majority of our work is still taking place in the Anchorage area. So next slide, please. For chlamydia, slightly different breakdown. 45% of cases of the 5,571 cases of chlamydia reported to EPI in 2021 were in the Anchorage Matsu region, 5% in the Gulf Coast, 17% in the interior, 7% in the Matsu. Those are broken out, apologize, so I'll fix that. 8% in the northern region, 3% in the southeast, and 15% in the southwest. So as we know, some of these infections are endemic to certain regions, and so we're still fighting those uphill battles to make sure we can try to get those people adequate access to care and treatment. Next slide, please. As we all know, so throughout the pandemic, due to staffing limitations, Gonorrhea and chlamydia have had limited follow-up for public health, so we haven't been conducting full-blown disease investigations on all these cases just due to programmatic limitations. So syphilis has kind of been at the forefront of our focus as those numbers increase. Also, the complexity of testing makes it a little bit more difficult. So this slide is the syphilis in Alaska by staging for 2021. There were 77 cases of primary syphilis, 117 secondary, 132 that were staged as early latent syphilis, and then 116 or 26% that were unknown duration. Of note, so again, reduction in in-person services means lack of documentation of clinical presentation signs and symptoms. I'll touch on it a little bit later, but especially with syphilis, gonorrhea, chlamydia, a lot of these have direct detection methodologies for testing. So nucleic acid amplification test confirms the presence of that infectious agent, test them, treat them, and that's acceptable. As we all know with syphilis, it gets a little bit more complicated because of the serology, combination serology, historical testing, documentation of the signs and symptoms. So 56% of the cases in 2021 were asymptomatic or had no documented signs or symptoms. 30% of those, we did have a historical test to narrow down that infection timeline. So next slide, please. So the 447 cases reported in 2021, 353 of them were in the Anchorage area, 79%, 2% were in the Gulf Coast region, 3 interior, 5% Matsu, 2 in the northern, 3 in the southeast, and 4 in the southwest. So again, very Anchorage centric. Next slide, please. So I did want to touch on the syphilis serology and some of the complexities and caveats with that. So CDC does require a combination of both reactive serologies for initial diagnosis. So there's 2 categories of testing. You have the non-treponemal or screening test. They're highly sensitive, non-treponemal specific, but there are frequent false positives. So ironically, aside from pregnancy and autoimmune disorders, which have always been a causative agent that we're aware of, there is some data to support that vaccinations also may have resulted in mild reactivity with this. So we have had some instances of false positivity where the only identified component might have been a recent vaccination. Again, low titers, and they tend to be not sustained, but this is the test that is associated with that titer, and I'll touch on that in the next slide and explain kind of what it is and why it's important. But then the second component is the confirmatory testing, which is a treponemal specific test. They are highly specific, they're treponemal specific, but after that initial diagnosis, they're not diagnostically relevant. So once they've tested positive, they'll always test positive. That non-treponemal test becomes more important for future infections, gauging efficacy of treatment and possible reinfection or medication failure. So next slide, please. So the syphilis titers and why they matter. So I really like this diagram because it shows that parabolic curve for those titrations. I wish it was this simple all the time, but it's not. But if you'll notice, there's a lot of wording in the periphery. Pay no attention to that. It's more about the line of the graph itself. From the time that they're infected, that titer will go up and up and up. Whether they're treated or not, it will eventually trend downward. As such, you can see those titrations fall on both sides of that curve. So oftentimes we'll hear providers say, well, your titer's this, you've had it for this amount of time. Unfortunately, absent signs and documented signs and symptoms or historical testing, we can't narrow that down to that point because they may have had it for a duration or they may have had it for a short period. So the frequency of consistent testing matters. Testing at post-treatment matters. With that, this is how we gauge reinfection. So if, hypothetically, we had a patient who came in, they test positive, they have a 1 to 32 titer, you treat them, the recommendations are 3 months, 6 months, and 1 year post-completion of treatment titer checks. The anecdotal statement is at 3 months, we expect it to be trending downward, 6 months, it should be half or less, and at 1 year, it should be non-reactive or 1-to-1. In instances where there's higher titers of a 512, 1024, all the way up, it may take longer for that titer to decrease back to that baseline non-reactive. So they may recommend additional testing at 15, 18, 21, 24 months just to make sure that that trends downward. Again, hypothetically, if a patient tests with a 1 to 32, 3 months they come in, it's a 1 to 16, 6 months they come back in and it's back up to a 1 to 128. At that point, we would suspect reinfection. So we conduct a re-interview and possibly retreat that patient, assess for treatment failure. But the titrations do become relevant. The guidelines for that is a 4-fold or 2 dilution increase. So if that 1 year mark, they're 1-to-1 or non-reactive, they come back in a year, 2 years later, and they have a 1-to-4. At that point, that would be considered a 2 dilution, or yeah, a 4-fold 2 dilution increase, which may be indicative of a new infection, or it could be indicative of a false positive based on some other factor. So it may require additional testing. At that point, we'd recommend follow-up testing in a couple weeks to see if the titer is sustained or increased. But those titrations matter moving forward for historical infection, gauging adequate treatment, and ensuring that treatment failure didn't occur. Next slide, please. So I put this slide in here to kind of reiterate those components, the relevance of accurate syphilis staging. So again, gonorrhea, chlamydia, MG, LGB, there's direct detection methods. Aside from PCR and dark field microscopy for syphilis, we're kind of doing a probable indication for clinical diagnosis. So it's a combination of serology, documented signs and symptoms, historical testing, not known exposures to current infections. So I put this up for 2 reasons. One, to kind of simplify that flow chart of if it's primary, secondarily latent, the treatment recommendations are that 1 dose of Vicillin or doxycycline 100 milligrams twice a day for 2 weeks. If there are no documented signs and symptoms, no historical testing, they're late, latent, or unknown case, it's the Vicillin times 3, 100 milligram doxy twice a day for 4 weeks. Serologic response, again, may take longer with the unknown or late latent, but it is notable if there are no clinician documented signs or symptoms, and we can't narrow that time frame, we do default to the recommendations of the Vicillin times 3. So taking that few extra minutes to document those signs and symptoms, what brought them in, may not only help reduce the amount of treatment, but reduce the cost of that encounter. Oftentimes cost is one of the biggest barriers, aside from availability and access. Cost is one of the biggest barriers to that treatment. We also have significant loss to follow-up after that initial dosing, just because the shots are uncomfortable. So be sure, check the dosages, 1.2 million unit syringes, so it'd be 2 syringes, 1 in each hip, and also that it's the LA and not the CR, so it's accurate medication. Also assess the penicillin allergy. I think last estimate, upward of 82% of people have a verbal penicillin allergy or history of penicillin allergy from an adverse reaction as a child. Take the time to ask those questions, assess what that actually looks like. A lot of people that state they have penicillin allergy don't. It helps reduce, again, medication compliance. Adverse reactions, the side effects of doxycycline often result in medication non-compliance. So that preferred first-line treatment for syphilis is the Vicillin. Also, I just want to briefly touch on congenital syphilis. I don't have a slide up for it as well, but there is legislation on the books for first trimester testing. So at first prenatal appointment, testing for pregnant females at risk and all new pregnancies. But there's also a push nationwide from the CDC and just clinicians in general to test again early 3rd trimester and get a time of delivery. If we can initiate the treatment 30 days, initiate and complete the treatment 30 days prior to delivery, we avoid those congenital syphilis cases. So be aware that those are on the rise, and that increased testing can help avoid some of these congenital syphilis cases. So next slide. All right, so on the horizon, I've had several questions over the past several months, and I know this is a conversation that's been had in the STI community for several years. But mycoplasma genitalium and lymphogranuloma venereum have both been discussed as causative agents for NGU and the variations of the treatment associated with that. At this point, they are not reportable conditions. There's speculation that in the not too distant future, CDC is kind of pushing that direction for it to be, but because of the testing, MGU is prevalent in men with recurrent, MG is prevalent in men with recurrent NGU, and they should be testing using nucleic acid amplification testing, FDA-approved testing for mycoplasma genitalium. It is a slow-growing organism, so they recommend a two-stage therapy approach using resistance-guided therapy. So if antimicrobial resistance testing is available, the recommended treatment regimen is doxycycline 100 milligrams BID for 7 days, followed by 1 gram of azithromycin, and then 500 milligrams for 3 days following, for a total of 2.5 grams. So that dual therapy approach, if in the event there is no resistance testing available, the recommendation is doxycycline BID for 7 days, followed by 7 days of moxifloxacin. These are available on the CDC website at the link as well. But I do know we've had several cases reported via phone, and then questions regarding whether or not it's a reportable condition, and then what the CDC recommendations are for treatment. Next slide, please. So again, touching briefly on lipogranuloma venereum, again, caused by C. trichomonas cerevisiae L2, 3, 1, 2, or 3. It can cause severe inflammation, invasive infection. So both of these are often diagnosed at fertility clinics. They're not often diagnosed at STI clinics, but at that point that it becomes a persistent problem, they do a little further investigation. This is kind of where that road leads. Again, nucleus or PCR-based genotyping is available for this, and the treatment is doxycycline 100 milligrams BID for 21 days. So these two components probably also helped contribute to the shift from the 1 gram azithromycin to the doxycycline regimen for chlamydia infections as well. So, next slide. All right, so again, I'm a disease intervention specialist too. We have disease intervention specialists here within the program that assist with STI investigations. Disease intervention specialists work to interrupt the disease transmission. We have expertise in communication, contact tracing, interviewing, counseling, case analysis. I've spoken with a lot of you on this call regarding specific case reports, treatment recommendations by the CDC, or just unique labs or examples. They are a critical part of the public health infrastructure and linking individuals to appropriate care. So we do conduct cross-organizational facilitation of treatment and testing, and facilitate prevention efforts. So we do presentations similar to this. We have a lot of trainings that we conduct and interactions. So we also do partner services, including partner notification, prevention counseling, and referral for other services. So partner notification is completely anonymous. The conversation goes, somebody that tests positive for insert infection, named you as a contact, need to see about getting you tested and if necessary, get you treated. So we do a lot of the partner notifications, prevention counseling, what it is, how you get it, how you stop it, anything from risk reduction to barrier methods or just general disease education. And then for our referrals, like I said, we do cross-facility facilitation for treatment or additional follow-up testing, but we do have limited connections for peripheral wraparound services to address barriers to care. So we don't do full case management, we don't do full wraparound services. It's just conduction of the facilitation of that disease investigation. Next slide. Reiterate some of these components. So we can provide historical STI screening and data. So if somebody tested positive out of state, we can also conduct out of state record searching for other jurisdictions. But specifically for syphilis, this is useful for historical titers and testing that may have been tested at a different facility. We don't often have negative tests unless it was in the course of an investigation, they've already tested positive, but we may be able to provide that titer history from another facility. We do use a variety of resources to assist in locating patients. So if you have somebody that just stopped coming to the clinic, you can't find them, they're not returning for treatment, they're not returning your phone calls, we do have unique resources available to us to try to locate them. We also conduct field testing, treatment, and referrals. So we do, oftentimes we'll tag along with TV sweeps or conduct outreach events and do testing. Treatment is limited to EPT only. We also do hepatitis C screening in limited instances, and those identified at risk, we may conduct a hepatitis C rapid. We're in conversations with the hepatitis program as well about expanding some of that due to overlap. We assist with staging syphilis infections and advise on CDC treatment recommendations for all STIs, and then we conduct partner elicitation and conduct partner services. So next slide, please. All right, so currently within the program, we do have 4 DIS. We have several positions that we're in the process of trying to fill as well. This is their contact information. So if you have case-specific questions regarding an individual patient, they can oftentimes look that up and reference that. You may interact with them in your normal clinic interactions as it stands. I was also remiss, we have a new GIS too, Hannah Guzzi, that is assisting with a lot of this, and she'll be assisting with some of the supervisory components of our work. If you, for some reason, and I don't anticipate it, but you can't get a hold of any of these individuals, you can also reach out to the EPI main line, 269-8000, and they'll refer you to one of the GIS. Next slide, please. And there's my contact information. Similar to Sarah, the phone number is available. I usually forward it to my cell when I'm out of office. As far as the emails go, preferably only patient-related questions, clinic-specific questions. We have had a lot of back and forth regarding encryption and PHI, so if there's any doubt, feel free to give me a call on this number. The voicemails on both phones are confidential, so I'll respond as quickly as I can. Thank you. Any questions now?
Thank you so much, Nathan and Sarah. Can you guys hear me? Okay, perfect. Feel free, everyone on, please ask. We have about 5 minutes for questions. Unmute yourself, ask questions, since we have Nathan and Sarah right here with us, or go ahead and type questions into the chat.
Hi, I had a question. I'm calling in actually from the lower 48. It's great to hear what Alaska's doing. And we also are just really wanting to get more DIS officers in a lot of the spots. They're really a lifesaver. So it's neat to hear about this program. I was wondering if either the state or the facilities up there get 340B pricing. That brings the penicillin cost down to a few cents rather than several $100s for a course. A lot of our federal sites do not have it, but our tribal sites do. And then any wisdom on partner services. We're really struggling contacting our patients. Some of that is self-imposed. The federal sites can only call patients and nobody picks up a phone call and you can't leave a voicemail. I'm wondering if facilities up there are able to text or message or somehow get a better return, because we're having a lot of trouble reaching our patients.
Perfect. So I'll field those really quick. One, we do have 340B pricing. To date, we have not utilized it, but we're in the process of navigating that process for that exact reason, to help reduce the cost of that treatment. I think the main barrier is just the paperwork associated with it, implementing those processes and making sure we verify eligibility and kind of navigate those components. So we're also navigating that process. If you have questions, feel free to reach out and we may or may not be able to answer that. There are some organizations that have 340B pricing and utilize it, but the state at present for the DIS component, HIV STI program, we do not utilize it. We're working on that though. Advice on expanding efficacy of the DIS work. Absolutely. Text messages, nobody answers phone calls anymore. It's just, we're in a digital age where text message seems to be highly effective. Social media resources, if you have the ability to set up Facebook Messenger, sending generic messages through social media accounts, oftentimes elicit responses. I am curious, what is the limitation to field work? Is it just a policy or procedure? Is it a field safety component with the federal aspect of it?
No, we don't have field work limitations as much as contacting patients. I often see our public health nurses will have to hand over patient information to their DIS counterpart, because the DIS can employ some of those communication methods that they can't as feds. So I don't know where the tribal sites in Alaska fall on that spectrum, if they have self-imposed kind of handcuffs like the feds, or if they're able to be a little more, have a little more latitude in their outreach.
Great question. I can't answer at a federal level, but as a state, I can say field work is absolutely essential. Knocking on doors is way more effective than 100 phone calls. And so those face-to-face interactions are highly useful. So, but I'd love to continue this conversation at a later date. Feel free to reach out. We can absolutely discuss DIS work all day long.
I think this is Leah. I'm in a room up in Bethel with about 6 of us, so my picture is not showing up with my voice. But I think one thing that we are working on at Alaska Native Tribal Health we struggle when we have a patient partner who the patient is Alaska Native or American Indian and the partner is not. And we struggle with figuring out how to get that patient there, specifically a penicillin injection. And I believe that we're starting to come up with a plan for that, and then going to hopefully be working with the state to come up with a better plan, because that's certainly a gap in care that we have.
I have something to say about that. My name's Abigail. I'm one of the women's health nurse practitioners here at YK. We have a program called Tiger Connect where we can actually text patients in a HIPAA compliant way. I don't know if you guys have the patient option at ANTHC. It doesn't work great here in the Delta because you have to have data, but I think it probably works better in the lower 48 where everybody's got data. So that's something to look into too, because you can compliantly HIPAA compliantly text your patient.
Thank you. Yeah, I have to learn more about that. I've heard it exists, but no one's using it. And you may have touched on one of the reasons why.
This is Lisa Ray. I follow up with patients for positive results. And sometimes if I haven't texted them before, I will text them and just tell them I have important information and ask them to call me. And that often works. And so I'm not giving information out over text, but then if they say that it's okay, then I'll move forward that way.
For my Bethel patients, it works well because they have data here and we have at least 3G. So, but it's just my village patients that doesn't work that well.